right, let's get started. Good afternoon, and thank you for joining us today. Thank you for our people who are joining online as well. My name is Catherine Mitchell, and I'm the Dean of the Social Sciences, and it's my great pleasure to introduce the proceedings tonight. This is the fourth of our 5 panel sessions highlighting the naming of College 10 for Representative John R. Lewis and celebrating his incredible legacy. So these panel sessions will be followed by a spring dedication event on May 6th, which Provost Flora Liu and Director of Student Life Sarah Woodside-Burry will tell you about in a minute. So I'd like to begin our event with a land acknowledgement. The land on which we gather is the unceded territory of the Awaswas-speaking UP tribe, the Ama Mutsun tribal band, comprised of the descendants of indigenous people taken to missions Santa Cruz and San Juan Bautista during Spanish colonization of the Central Coast, is today working hard to restore traditional stewardship practices on these lands and heal from historical trauma. So as some may already know, colleges 9 and 10 have long held a special relationship with the social sciences. We hold many of the same values. These include attention to community partnerships, as well as global events and circumstances, care about relationships, both inside and outside the university, and concern about social justice in many different dimensions. Additionally, we are drawn to research and instruction that engages the politically and socially relevant questions of our day, and faculty and staff who think about equitable and just ways to approach those questions and imagine and work towards fair-minded and sustainable solutions. The panel session today on pathways to thriving communities fits perfectly in these traditions. Speakers are all concerned with thriving, which is such an important way of approaching health. We're not thinking about deficits, we're not thinking about pathologies, we're thinking about well-being itself. That's what we need to emphasize. How do we get to well-being? When we think about well-being, we're thinking about our families, we're thinking about our friends, we're thinking about the campus, the community, we're thinking about the planet. Thriving helps us to move beyond the health equals medicine, and a degree in human biology equals a step towards getting into medical school. The concept of thriving takes us to the wide range of factors that go into healthy lives and environments, from clean waterways to food systems, from nutrition to access to healthcare, from thinking creatively and with diverse perspectives to flourishing in local neighborhoods and a medley of different types of jobs. We have recently established at UCSC a program in global and community health that has at its heart this understanding of these broader social and economic determinants of health and of well-being. Please feel free to ask me more about it at a later date if you're interested. So our panel tonight, our amazing panel tonight, is going to drill down on how we thrive in so many different ways and what the challenges are to getting there too. Because of course, one thing we know from the last 2 years especially is that both people and the planet are in trouble right now. And the important work we do in the social sciences and health and other spheres is calling out the kinds of injustice and inequity that have led to those troubles, but also offering new ways of thinking and new practices for greater well-being, pathways to thriving. So thank you again for joining us this evening. I'm going to turn it over now to Flora and Sarah.
Hello, everyone. I'm Flora Liu. I'm the provost of College 9 and College 10, soon to be named after John R. Lewis.
Hello, everyone. My name is Sarah Woodside-Burry, and I'm the Senior Director of College Student Life here at College 9 and College 10. Together, Flora and I co-lead College 9 and College 10, soon to be John R. Lewis College, and our partnership across both academic and student life side reflect the unique living and learning environment that is the college system on our campus. At College 10, our theme is social justice and community, and it imbues all that we do, both inside and outside of the classroom. So just as John Lewis committed his life's work to racial justice, voters' rights, and community organizing, it has been our commitment at College 10 to support ourselves and our students to become agents of social change.
Tonight, the fourth event of this series, we continue featuring UCSC faculty and community leaders and the ways in which their work reflects the values that John R. Lewis exemplified. As Dean Mitchell so aptly and articulately expressed, that today's theme, Pathways to Thriving Communities, we'll discuss how these panelists conceptualize this important idea of thriving. Of course, all of us fully recognize that the COVID-19 pandemic has revealed the inextricable relationships between environmental degradation, economic precarity, racism, social deprivation, food insecurity, and unsafe living and working conditions. Health disparities reflect and exacerbate a multitude of inequities that John Lewis challenged throughout his life. From the establishment of Freedom Clinics with the Student Nonviolent Coordinating Committee, to his promotion of health equity, Medicare, and the Affordable Care Act while in Congress, John Lewis advocated for healthcare as a cornerstone of thriving communities.
This Necessary Trouble series has been a partnership between College 9 and College 10, the Institute for Social Transformation, the Division of Social Sciences, and the Center for Racial Justice. And so we'd like to just share a few details about the event today for those of you joining online and in person. The format of our event is going to start with opening comments from our wonderful moderator this evening, and then followed by lightning talks from each of our panelists. After which there'll be a moderated discussion amongst the panelists, and then we'll turn it over to all of us for question and answer. And we'd like to center our students in the audience today. So students, if you have questions, please let us know. If you're in the room, you can raise your hand first for those Q&A. If you're on Zoom, you can go ahead and indicate that you are a student on the chat. And that's in fact how we'll be doing the question and answer period on chat with our Zoom participants. Is go ahead and at any time that you have questions, feel free to add them to the chat, and Chris Benner will be leading that at the end of our session. And just wanted to let you all know this event will be recorded and posted on our website afterwards. So if you miss anything that these amazing folks have to share with us, you can always go back and watch later.
I now have the pleasure of introducing the moderator of the event tonight, Dr. Lynnea Beckett. She is an adjunct assistant professor at Colleges 9 and 10 and the founder and director of the Apprenticeship in Community Engaged Research, or ASER program. As an anthropologist of education, Dr. Beckett uses critical ethnography and participatory methodologies to examine settler colonial and white supremacist practices often normalized in school and community relations. She conducts community engaged research in Watsonville on issues of educational equity, informal STEM learning, food sovereignty, and water justice. Welcome, Lynnea.
Thank you. Good afternoon, everyone. As Flora mentioned, I am the director of a community engaged research and learning program here at John R. Lewis College, and I'm very excited to be here for this panel to engage in such an important conversation about thriving as part of these lightning talks, to really highlight and also commemorate John R. Lewis's life and legacy. So before and during the civil rights movement, the Highlander Folk School emerged as a hub of learning, a place to train burgeoning activists, to share ideas, and to organize what would become some of the most impactful and transformative actions of the civil rights movement. The Highlander Folk School started in 1932 by a handful of folks inspired by the folk school movement and popular education. They set out to, in the words of Ashley Woodard Henderson, who's the current co-executive director of Highlander, quote, bring people together to learn new knowledge that could only exist if these folks came and sat in some rocking chairs together and learned from one another and taught one another, and then took this new learning back into communities to change their own material conditions as directly impacted people. The iconic image of the Highlander Center is the rocking chair. In the room, a circle of rocking chairs for folks to share their experiences, to discuss the environmental impacts of toxic seepage into their working class communities, or the racial violences of segregation. The Highlander Center served as a site to rest together, to recharge together, and to organize. At 18 years old, John R. Lewis attended a workshop at the Highlander Folk School. He wrote in Walking in the Wind, quote, "This was the first time in my life that I saw Black people and white people not just sitting down together at long tables for sharing meals, but also cleaning up together afterwards, doing the dishes together, gathering together late in the night in deep discussion and sleeping in the same cabin dormitories, men and women separated, of course," end quote. Highlander was a radical space for folks to be together. A few years later, Lewis spoke at a Highlander workshop as a student activist about the student presence in the Nashville sit-in movement. In this event, he shared how students organized across their respective schools, united by the nonviolent movement with the common goal of desegregation. Students moved into the streets, into restaurants, and into the community, becoming what John Lewis called, quote, "a people's movement with no heroes and mass leadership." So I bring up the Highlander Folk School as part of John R. Lewis's training as an important place for many civil rights activists to emphasize the power of student activism and the importance of a social justice-oriented educational experience grounded in lived realities. Here at John R. Lewis College, we learn from the Highlander Folk School's pedagogy and aspire to implement a similar pedagogical strategy with our students' community. In the colleges, the themes are social justice and community. These themes are interdisciplinary, and through our co-curricular programming activities and residential community, we're designed to create a kind of living and learning community that really moves beyond the classroom walls to support students to sit together, to share their lived experiences, to learn from each other, to develop astute critical perspectives of social injustices that both they and their peers face. Students learn important human rights discourses while they hear from leaders on the forefront of powerful social struggles for racial justice, environmental justice, labor rights, trans rights, mental health, disability rights. Many of our students understand oppressions are interlocking and intermeshed and require creative, embodied, relational, and organized responses. And at John R. Lewis College, we're committed to having conversations about thriving with our students and mobilizing towards visions of thriving. If we really take seriously and honor the lived experiences of our students and the communities that they come from, and also understand that the students in their communities hold all the knowledge and the wisdom that they need to address the injustices that they face. If we really take these knowledges and experiences seriously, honoring them and upholding them, then what is our role at John R. Lewis College and the university more broadly? What is our role in supporting student activism and our commitment to the health and well-being of communities of color, working class communities, immigrant communities, LGBTQIA communities, and all the communities that our diverse student body represents? As a residential, co-curricular, and academic community, John R. Lewis College is uniquely positioned to explore how to not only serve the student body that comprises the college with important reflexive embodied educational experiences, but support student activism that can and should reach beyond the campus community. Our students work in a variety of off-campus community contexts. Some have found their way to thriving on campus through their community work as students. Here at John R. Lewis College, we seek to serve students and their respective communities, not only in envisioning what thriving means, but supporting the hard work for dismantling injustice to support community thriving. So today we're going to hear from scholars and community leaders as we ask, what really does it mean to thrive, and how can we get there? How can we as scholars and community members uplift community efforts, whether those efforts are on campus, in our student communities, or off campus, and move towards thriving? So to begin the lightning talks, I'd like to introduce with our esteemed panelists. I'd like to start with James Doucette Battle, Professor of Sociology.
Thank you, Lynnea. I'm James Doucette-Battle, Assistant Professor in the Department of Sociology, Affiliate Faculty in the Department of Anthropology, Science and Justice Research Center, and the Global and Community Health Program here at UC Santa Cruz. Glad to be here. Thank you for all of you for joining. In the 116th Congress, John R. Lewis introduced the National Institute on Minority Health and Health Disparities Revitalization Act, and it was passed on March 15th of last year. It provides grants for critical research into minority health disparities. Congressman Lewis, a member of the powerful House Ways and Means Committee, was the chair of its Budget and Oversight Committee as well. A tireless proponent of health justice, he pushed for the passing of the Affordable Care Act and increased funding for Medicare. Lewis understood, like the Black Panthers and other social movements at the time, that social justice cannot be decoupled from health justice, and that thriving communities depend on both. In my work, examining type 2 diabetes among African descent communities and efforts by clinical and public health stakeholders to recruit African descent communities for clinical research on type 2 diabetes, I have a chance to examine the ways in which African descent communities are imagined in the sense used by or first offered by Benedict Anderson. The ways in which the African descent community is imagined, recruited, and attempts to communicate put forth. This vision of a thriving community, this notion of an imagined community, rings true, particularly given the dynamism of the category itself. Today, 10% of the African descent community in the United States has an immigrant background. So how do we envision these communities? And how do we envision these communities historically and within the contemporary? In terms of the social contract between society and the communities that are racialized, gendered, and otherwise asymmetrically positioned in relation to power. Answering these questions can better help us understand things like vaccine resistance in the African American community and other communities. What are the politics of refusal? What are the rationalities behind the irrational or the seemingly irrational? And what are the solutions to this? Well, in my work, one thing that has rang true is this notion of trust. How is a violation, how is an abrogation of the social contract between science, society, politics, and the market, and the categories that we all inhabit? How do they reify and reproduce inequalities within the society and inform the politics and the practices of refusal that we've seen in many instances over the last 2 years in particular? I'm still thinking through possible solutions to this, along with my students who are extremely curious and have much to offer in terms of this conversation and the categories to which they find themselves inheritors of and otherwise arbitrarily seen as objects to be placed within, the ways in which race and ethnicity have been seen, and find new ways of making claims to be rooted in biology. So this raises questions of trust, whether it's for vaccines, whether it's for notions or for practices that seek to recruit minoritized communities for drug trial and clinical trial research. What does this question of trust mean in the 21st century in ways that John R. Lewis's work in the 20th century can serve as an informative and hopefully generative template to work from? So in this examination, in this exploration, in this quest for truth and health equality, I'd like to complicate notions of progress. What does that mean? And how has the pandemic revealed the ways in which, as Bruno Latour said, we've never been modern? So with my students, I've been thinking through and working through these questions with colleagues such as Nancy Chen, trying to find ways of bringing students into conversations around health disparities, the pandemic, and environmental change here locally, regionally, and nationally. I join you to help to continue to participate in this quest, in this exploration, in this search for justice. Thank you.
Hi, I'm Alicia Riley, Assistant Professor in Sociology and core faculty in the new Global and Community Health program. We find ourselves 2 years into a global pandemic that's taken millions of lives. Headlines warning of the unequal toll of the pandemic have become familiar and mainstream. And in the face of so much documentation of health disparities, it's easy to feel overwhelmed and to wonder if the disparities in our communities are intractable. But the data on this pandemic and on health disparities in general actually tell a very different story if we look closely enough. I'm a population health researcher who uses quantitative data to study differentials in health. The study of health disparities is marked by a long and problematic history of beliefs in biological determinism. For centuries, differences in health between social groups have been used to naturalize inequity, to obscure it, and to shift responsibility for health to individuals. While important progress has been made documenting the social determinants of health, I worry that old assumptions about the inevitability of health disparities that were based in biological inequality have been replaced by new assumptions about the inevitability of health disparities that take for granted social inequity itself. Assumptions that social inequity is somehow outside the scope of public health research and action. This reluctance to link dynamics in social inequity to health is reflected in the ways that we collect data. In the US, surveillance data generally only contains information about age, sex, race, ethnicity, and place. And in the absence of better data, it's easy to end up with explanations that lean on stereotypes and assumptions. For example, throughout the COVID pandemic, we've heard racial disparities in rates of death and hospitalization explained with reference to higher rates of underlying conditions, often without further critical examination of the socioeconomic patterning of those conditions. And this reluctance to link social inequity and dynamics in social inequity to health is also reflected in the ways that we interpret data. So early in the pandemic, I went on the website of a local health department in California, and there was a post listing the 4 reasons why the COVID pandemic has had such a severe impact in Latino communities. And one of the reasons listed was that Latinos, quote, often show more physical affection. So this is, of course, false and deeply problematic, but it's also consequential because public health announcements carry authority. Explanations of COVID inequities that are based in stereotypes or which place blame on individual biology lead to flawed public perceptions that these issues are inevitable, or that they must have very little to do with our policy choices. But if we take a closer look at disaggregated data that explores social vulnerabilities within racial groups and over time or over place, a different picture emerges that reveals the modifiability of health inequities. For example, some of my recent research with colleagues at UCSF and Stanford looked at the relative disparity in COVID deaths between Latino and white Californians and found that it varied over the pandemic, widening in the first weeks of the pandemic and closing in the first half of 2021. In a different paper published last year, I showed that excess death during the pandemic among Latino Californians was higher increased more among Latino Californians with low-wage essential jobs, such as agriculture jobs, than those with non-essential jobs. And even among Latino essential workers, immigrants with the lowest education had the highest increase in excess death. So why are findings like these important? Because they reveal that health trends vary within and between racial groups, depending on intersecting factors like our jobs, our income, our education, whether we feel comfortable asking for protections at work, whether we feel safe seeking medical care, our political rights, and so much more. In my field of population health, the evidence linking health inequity to social inequity grows stronger by the day. But too often, researchers stop there and they treat the social inequity part as fixed or somehow out of bounds. And the problem with taking social inequity for granted is that we miss opportunities to study the ways that systems of social stratification are constantly being contested and remade, sometimes for better and sometimes for worse. For me, I look no further than a park near where I grew up along the US-Mexico border to see how systems of social inequity can change. This is former First Lady Pat Nixon visiting Friendship Park along the US-Mexico border in 1971. On the left is the Tijuana Bull Ring, and on the right is San Diego. Back then, the border fence was just some loose barbed wire, and Mrs. Nixon is quoted as asking, "When is this fence coming down?" Well, the border fence didn't come down, and growing up, I watched as it turned into a reinforced wall, and then two, and now this grate. This contrast is a visible example of how the system of immigration enforcement in the US changed over the last 50 years. And we can ask, what has this dramatic transformation done to health in our communities? Research shows that the increasing criminalization of immigrants has created new inequities in community health. For example, colleagues of mine showed that a major immigration raid at a meatpacking plant in Iowa led to babies born to Latina mothers in the state having worse birth outcomes the following year. This is the way forward. I think this is the way forward for health disparities research, to show that disparities emerge and evolve in response to policy, social movements, community resistance. By using data to show that health disparities aren't just present, but that they're movable, the data becomes a way to challenge dominant narratives that protect the status quo. John Lewis's legacy reminds us that to assume social inequity is inevitable is to give up our power. We live amidst systems that expose some communities to health protective resources and others to health harms. But we can and do change these systems. The inequity is not an inevitability, it's a choice. Thank you. Nancy.
So, good evening, everyone. My name is Nancy Chen, and I'm professor of anthropology, as well as the Associate Dean of Health, Wellbeing, and Society here in the Social Science Division. The Honorable John R. Lewis knew firsthand the importance of health as essential for thriving communities, and he worked hard throughout his career to build foundations for access to health that would transform survivance into thriving. As a medical anthropologist, I study the intersections of food, medicine, well-being across cultures to understand different notions of health. The intersections of individual bodies, social determinants, and political forces are especially significant for understanding how health is not a static condition, but the result of dynamic social, historical, political, spatial, and cultural practices that shape this evolving category. So in what follows, I address 3 ways in which we can continue along the path that John R. Lewis has laid out for students, community organizers, health practitioners, essential workers, medical advocates, and health researchers to move forward. First, food is medicine. It's not a coincidence that all the classical systems of medicine, whether Ayurveda, Chinese, Greco-Islamic, or even indigenous systems of healing, considered food to be the front line of medicine. Ensuring access to healthy, nutritious foods, especially for those who work hard to bring food to tables, ensures that everyone can thrive. Food can enable well-being and restoration on an everyday level. Here at UCSC, the Blum Center's innovative work on basic needs with, as well as participation in the UC Healthy Campus Network offers inspiring ways for student researchers to map food insecurity, as well as engage in policymaking that ensure nutritious foods for physical and mental well-being at all ages. Second, well-being is social. Throughout this pandemic, as we've learned from our panelists, we've relearned the basics of public health measures. Rather than think of health as an individual state of being, well-being reflects intensely social determinants, which shape not only one's health at a given moment, but bigger frameworks. Landscapes and zip codes reflect where we live in relation to air, water, food, and medicine, especially in this moment of dramatic climate change that require essential workers to persist, even in spite of hotter weather, fire, smoke, and flash flooding, sometimes all at the same time. Over the past 2.5 years, I founded and helped mentor different cohorts of the Global Community Health Wellbeing Fellows. Starting at the onset of pandemic, our student fellows conducted significant research on water and environmental justice in Salinas and Pajaro Valley, reproductive health for unhoused women, domestic abuse, plant medicines, immersive virtual reality for rehabilitation, mentoring Latinx youth through pandemic, working conditions of incarcerated firefighters, digital media for incarcerated persons, including environmental racism and ration medicines in the Dominican Republic, as well as Palestine and Israel. Their research and learning shared stories of survivance from community partners offers insights onto possibilities throughout systemic upheaval and what recently departed Dr. Paul Farmer called structural violence. Health is not achievable without first healing from long-term harm, especially for the most vulnerable. Third, beyond survivance, new generations of thriving communities. This is an iconic image of John R. Lewis and Dr. Martin Luther King at the beginning of their historic march from Selma to Montgomery in 1965. And they're wearing leis sent to them by the Reverend Abraham Akaka from Honolulu. The power of this image resonates with the present moment. Asian American Pacific Islander solidarity, then as well as now, for Black Lives Matter, and responding to hate crimes against Asian American Pacific Islanders matter all the more. While BIPOC communities have survived for centuries, despite generational trauma, we can do better. We can move forward as John R. Lewis's legacy urges us to thrive together. This year, the Global Community Health Wellbeing Fellows program pivoted to regenerating the community herb garden at the UCSC Center for Agroecology with the guidance of Assistant Manager Kelly Matsushita Singh. The GCH Wellbeing Fellows are growing herbs, especially for BIPOC communities, such as campesinics for wound care, offering organic herbs, which would not otherwise be accessible. By cultivating the land and each other, these fellows are experiencing the value of connecting land, medicine, and well-being. By growing together, it is possible to prosper and thrive, even in facing new challenges brought by climate change and pandemic. By widening community pathways for future generations of health professionals, researchers, and community health advocates, we can ensure thriving communities. Flourishing together is the ultimate act of showing up for each other to make better futures for new generations. Thank you.
Thank you, everyone, for having me. My name is Dr. Christina Gamboa. I am a physician and employed at Salud para la Gente, located in Watsonville, California, in the Pajaro Valley. It is an extreme pleasure to be here sitting with my esteemed colleagues and panelists, and I appreciate the invitation to participate in this event, and also want to give recognition to my organization, all their great work and support in doing this as well. As physicians, historically, we have been trained to examine health outcomes as a result of biological processes. However, for over a decade, it has been professionally recognized that there are external factors that deeply impact the health of an individual and a community. These external factors, known as determinants of health, are important to examine when trying to answer this important question of what makes a community thrive. Why is it that some communities thrive more than others and have better well-being than others? The Office of Disease Prevention and Health Promotion described determinants of health as the range of personal, social, economic, and environmental factors that influence health status. As a clinician and a full-time clinician, in addition to being a clinical director, I wanted to share a couple cases and encounters with patients to really help drive home this point of how determinants of health play into real life medicine and into the exam room. The first case, this person is identified as a male, 25-year-old person who was diagnosed with COVID in early 2020. Time warp here, forget how long we've been in the pandemic, in a pre-vaccination time period after testing due to work exposure. During notification of his positive results via phone consult, he revealed the following external factors. When discussing his type of employment and place of employment, he revealed that he worked at a meat packing company, worked in very close proximity to other persons, and worked in assembly line fashion. He had some mild symptoms of COVID, but truthfully was not quite clear at that point what COVID really was or how to go about expressing what his concern was. He also stated that it was very important at that time to continue working, as if him deciding not to work would significantly impact his family, his ability to pay for their necessities, including rent, and was afraid that if he didn't present to work, he would lose his job. In discussing standard precautions recommended by the CDC of isolating, he shared that he and his wife rent a room in a house. They share a bedroom and a kitchen with other tenants who also include a couple and a family with 2 young kids. He was very concerned for their well-being and also expressed concern that if he shared with him his positive results, that he would have nowhere to go, and that he was very thankful for them that they have been patient with him, as there has been months where he hasn't been able to pay rent and or has postponed it until he could. We had a follow-up call a few days later to check on symptoms, and medically and biologically, he was doing okay. He was feeling on the path to recovery. However, new things had started to evolve, and there's expressed feelings of feeling very overwhelmed, very saddened by the diagnosis of COVID, very isolated. He's an immigrant from Mexico and has not seen his family in over 10 years and does not have the opportunity to return due to documentation status. Case number 2, a little bit closer to what I do as an obstetrician, and to give an example of the determinants that exist outside of a COVID era. This patient is a 31-year-old woman who presented for routine pregnancy care at approximately 4 months in her pregnancy. At her first visit, it was determined that she did have a high-risk pregnancy with twins, high blood pressure, a history of diabetes in her previous 3 pregnancies, which she states she thinks has gone away. During the duration of her pregnancy and subsequent visits, the following external factors were revealed. When asking about the reasons for initiating pregnancy care later than the recommended time of in the first few weeks, she stated that in the past, she had only received insurance during her pregnancy as she could not qualify in other circumstances, and that in this pregnancy, she had a plan to apply for pregnancy-related Medicaid, but that she was concerned of how this would change her pathway to naturalization. She expressed a lot of excitement for her pregnancy of expecting twins, but admittedly was very concerned of how adding 2 more kids to her family would impact her financial health and her ability to supply food and pay rent and support her family in other ways. She presented to clinic often alone, And when asking about her social support system, she stated that she does have a brother in Monterey, but she tries not to bother him. She has a partner who she spoke very fondly of, but stated that he was incarcerated at the time. She's unclear on the reason, but was very fearful of his risk of being deported. She stated that she has an oldest 17-year-old daughter that she spoke very proudly of, and that she was a primary support person for her, and spoke that she would be going to college soon and was very proud that she spoke 3 languages, Mixteco, Spanish, and English. As she approached her pregnancy, she stated that she was agreeable to doing our recommended plan of a scheduled labor, which means picking a date to go to the hospital. But when pulling up a calendar, she humbly said, I can't go to any of those dates. I don't have transportation. So as seen as these examples, determinants of health reach beyond the boundaries of traditional healthcare model. There are several things that were exemplified here that impacted patients beyond a biological process. Those things include a work environment, access to care, housing, transportation, mental health, the list goes on. In practice, social determinants do not live in isolation. They can be complex, they can cross multiple sectors. It's important to have partnerships and effective tools to address the issues that perpetuate health inequities. The creation of partnership among sectors and creation of interventions that target multiple determinants enable us to build and sustain thriving communities. At Salud para la Gente, it is with great pride that I am able to share that we have several mechanisms in place and a community health department that allows us to link patients to services and community partners to address these determinants. Some of our partnerships existed well beyond COVID, and they include but are not limited to our MedLegal partnership with the Watsonville Law Center, PVUSD partnerships, and partnerships with several nonprofits that allow us to provide vouchers and other support for patients when we encounter that these are obstacles to their care and well-being. Some of these partnerships, as I mentioned, existed prior to COVID. However, the pandemic, as we know, definitely strengthened these collaborations and additionally called on partners to approach creating solutions in a new way. Approach creating solutions through a collaborative impact model. Utilizing this model of community work groups has been to address multifaceted issues that have common themes. I'd like to emphasize that our vulnerable communities, which have been historically marginalized, are resilient. The solutions to erasing health inequities are complex, but I believe it is possible to create a thriving community in our healthcare system if our healthcare system recognizes this complexity and creates solutions in a meaningful way. The legacy of John R. Lewis is a powerful reminder of the importance of meaningful work. I'd like to congratulate the university on the renaming and hope his legacy inspires future leaders, particularly in the field of healthcare. Thank you.
Great, thank you all. So I would just want to take a moment. Let's just kind of drink in what we've all heard. And I'd like to ask the panelists to, if there's something that you heard today from your colleagues that you'd like to respond to, the floor is yours.
I'd like to respond to James's comment and sharing his pathway to really examining how is it that we recruit our communities to participate in research. I think that's one thing we've talked about in different ways of the data and recreating what healthcare looks like in our health policy systems. And I think that that is something that's often not examined. And I can see that firsthand speaking to a patient and talking to them about why I'd recommend they participate in research. Often there's resistance in different ways that's not very clear. It's not one way. There's so many narratives in our history that it's not a one-size-fits model. And I really liked hearing about that. And I think that just even mentioning that in this kind of form really hopefully will allow us to sit with that, to think, okay, how do we look at engaging our community in so many different ways beyond just public health and messaging, but research and direct interface with patients and addressing these resistance that exists with reason.
I think along those lines, one thing that I noticed in my interviews and my field work is that individuals, minoritized communities by and large, have really good relationships with their GPs, with their primary healthcare providers. But biomedicine as an entity with a history and a specter looming over it elicits a completely different response in some of these people. than their actual subjective personal relationships with their GPs. So in terms of those conversations being had, I think that the diversity of people in medicine, practicing medicine, whether it's through different types of minoritized statuses, gender, ethnicity, I think will go a long way toward communicating the message in ways that can engender trust and confidence. The other thing that I found in my work was that when it came to type 2 diabetes education, community health workers play a vital role in diabetes education in communities, these imagined communities. And as I argue in the book, community health workers should be included among those who would qualify to become diabetes health educators or diabetes educators or certified diabetes educators. And there's some professional gatekeeping that goes on because type 2 diabetes, obesity, these are not just communities, but these are imagined as markets. And there are many people who are working on the inside, minoritized people, who understand that there's a pretty big market here and there's enough of the elephant for us to chop, and let's get with it because there's money to be made. The way we eat has changed, particularly during the pandemic. We're being urged through the media to eat things that perhaps should not go into our mouths. And we have a pharmaceutical industry which is ready to treat the after effects of these ways of eating and being in the 21st century world. So yes, the diversity of practitioners, the relationship of practitioners to these communities, and the relationship of these communities to science in general, as we're finding writ large in this country and other countries, is that the relationship between science and society continues to be a fraught one.
Yeah. Yeah. You mentioned refusal in some of your work, and I think it ties on to that, continues to be a fraught relationship. Can you speak a little bit more to how you're using that term and through what you're seeing in your work?
I use the term refusal partly informed by Ruha Benjamin's notion of organized ambivalence that some communities have in ways which bespeaks of a certain ethos, a certain epistemology, a certain way of being, of thinking, and an ontology of being in the world that sometimes when I find myself, for example, going back home, back to my own community in which I grew up in, I'm usually exposed as the academic who needed to go away. And I have a hard time sometimes communicating with even my own family. So if I could tell a story, last spring, a party was organized for my mother and my aunt to celebrate their golden birthdays. And I'm not going to say their ages, but the DJ who was hired by my cousin to play music at the event, his family decided that they were tired of sheltering in place and they were going to have a massive family gathering. It was recorded, put on YouTube, 30 or 40 people in a tiny kitchen in an inner city neighborhood, all having a great time. Within a week, one sibling was dead. The next day, that sibling's sister dropped dead in the driveway. And the day after, the third sibling passed away, all from COVID. There was a fourth sibling who was spared because they decided that they were going to stay home because their significant other had a pre-existing condition and they didn't want to expose them to the risk. Nonetheless, the DJ shows up at the party. No one's wearing masks. I'm the guy from California wearing a mask. Fortunately, everything turned out well. But in conversations with people about masking, about social distancing, about vaccinations and so on, it was extremely difficult to get through. So this is why perhaps even the academics need to stand aside and let the community health workers have these conversations. People not only have the eyes and ears on the communities, but also know how to listen and speak to these communities.
And I think to add to that, sorry, that kind of sits with me because I think that's what we saw even locally in our community, in the Latino, Latinx community, was that the messaging, it was kind of the wires were getting crossed, and we saw a lot of people duplicating efforts, which were all amazing efforts. And it took a second for community stakeholders to say, you know what, let's just take a step back and let's make one centralized message that can hit all the points in with all the different perspectives. And that was Pajaro Valley, or PB Safe Lives. And that included Salud para la Gente, other organizations. And I think, again, that speaks to the power and the messaging and the power really sitting back to say, okay, well, what kind of pre-existing history and narratives do we need to take into account that impact how the messages will be received? And, having this concentrated messaging and not duplicating efforts is really important when we're trying to really make the change and really educate people with preserving their autonomy and preserving their, their willingness to do things.
Does anyone else have comments that they'd like to, or things that they'd like to respond to from something that the lightning talks brought up for you? If not, I'm going to go into another question. You all were talking about that health is dynamic and evolving and encompassing social and historical factors and impacted by inequities and injustices, and really a model that takes account for more than human relations as well. So given this frame of how we've been thinking about health in really broad ways, what is thriving? Is it a destination? Is it a process? Is it a state of being? What does it mean and what can it look like? And is it fleeting? Is it?
Maybe I'll start. I think what the legacy of John R. Lewis has really taught me in just the short time of preparing this talk is that thriving is not just an individual achievement. It is a social act, and it's about caring, but it's also ensuring, in many ways, thriving is not simply healing. It's really about health equity. And I think that's a theme that really all of our presentations really touched upon, is that thriving is not possible unless there's equity in terms of people who come into the clinic, or communities that are marginalized, that have deep historical context of distrust because they've not been treated equally. And so I think for me, thriving really is the basic foundation has to begin with health equity. And we can build up even more. There's so many wonderful things that we can do with well-being that I like, not so much the privatized well-being, but the more inclusive forms of well-being. So that's just a start.
I love that thriving is a social act. And I think that I also am frustrated by the idea of thriving in an individualist sense. And I think that it's easy to think about thriving in this framework of maximization, of efficiency, that if only we maximize resources and have more money and more power and more medicine, and hoarding and exploitation. And I think that, that's what's interesting, is that to me, thriving has to be about balance and not about maximization. There has to be a point that is enough, that isn't more. And I think that this is really what is so interesting, as someone who's teaching about population health history right now and thinking about dramatic transformations in life expectancy and dramatic reductions in child mortality. These achievements, in the name of helping us thrive and be healthier, we have maximized health and continue to our limits, right? And continue to push those beyond. And as a result, our population grows because we all live longer, and that's wonderful. But this blindness around maximizing without an attention to balance isn't sustainable. And so I think that that is really what I'm thinking about. And I think it connects really well to what you're pointing out here around how thriving has to be a social act. And that we have to think of it as a concept that is experienced socially, and that just focusing on what does it look like if thriving is balance, if it isn't maximizing.
I'd like to add to that too, that I agree that it's everything that my co-panelists have said, and that it's really, there's so much diversity in that. It's on a continuum. It's not this fixed point of we get to this end of the road, and once we've gotten to that point, we can check off the box for thriving. I don't believe in that model in any way. I think the other big component of it is that thriving, if we look at a community population, there's pockets of communities that define thriving differently. It's not this blanket of, all of Santa Cruz County is doing great because our numbers are low. If you look at Pajaro Valley and niches, they're not doing great. Or you look at all Latinos, depending on your country of origin, depending on different factors, they're not all doing great. So I really think it's also important to recognize the diversity that exists in community, in race, ethnicity, and all the things that make outcomes different. But before we talk about and mark off the box of we're all thriving, because there's so much diversity that exists. I mean, that's one thing that I, as a Latina from Mexican-born immigrant, or my parents from Mexican-born immigrants, is this notion that, you can capture Latinos with one column of data. And there's 60 million different ways to be Latino in our country. That's how many Latinos there are. And so, I always look at data with just this kind of like question mark of, what's their country of origin? Where do they reside in? Is it rural? Is it urban? And there's so many things to my point that, again, we really have to look at things in more carved out ways to really see where is it that the disparities still exist when on a zoomed out perspective, we think that they're thriving.
I also agree with my colleagues here, but I'd also like to add a little bit of input here that might be a little bit just for thought. This notion of wellness and thriving and health. Ostensibly, we can agree that health can be measured, but can well-being be measured? We have the physician here. All kinds of thoughts are coming up here. So it's like, we know for small children, we have this notion of failure to thrive. But why does that get cut off at a certain age? How can we assess thriving throughout the life course? Are there ways of perhaps establishing some guidelines for assessing what that might look like? Or as we get older, is the notion of thriving something that becomes increasingly less corporeal and more psychological, more emotional, right? More social. And I'd just like to perhaps use that as a provocation for us all to think a little more about what do we mean by wellness. We know that major hospitals over the last 20 or 30 years have been falling over each other to establish wellness centers, because that's what patients have demanded, rather than being seen as a collection of symptoms and localized organ pathologies. So wellness centers have been springing up all over the place. But this is still occurring within a larger social context of food apartheid, lack of access to equitable healthcare, so on and so forth. So I just like to, and perhaps through the efforts of this college and the students and my colleagues here, we can think a little more and find ways of creating a different type of metrics, if that's what's called for assessing just what thriving means.
So I heard you also talking thriving as a social act and health equity or health equality. Even the notions of these wellness centers popping up, yet they're popping up seeming to have a blind eye to all the other inequities that are surrounding them. What is the role of solidarities in thinking about thriving? And if we are, in fact, kind of troubling and expanding notions of health and health disparities and thinking about them as so intersectional, how could we begin to kind of I ask the questions, what are the types of conversations that we might need to start having that would potentially lead us to finding those metrics that you're speaking of?
I'll pass that along.
Well, I want to jump in because something that came up for me as I was listening to James speak and with your question is that we defined thriving in contrast to these things that we're not naming. We defined thriving in contrast to a fear of, this failure to thrive, the fear of that. We defined thriving through our betterness over something else. And so as long as I'm better than this other thing, I'm thriving. I think that's really, especially when we think about what's happening in the American context, this is what I think I'm interested in really challenging, is because I think that if we chase that, we all fail. And because of the ways that thriving can't happen unless we thrive together. Like if I define my health and well-being and thriving based on a comparison or a fear of pathology, we miss that. And so for me, the solidarity comes in there, is that is the path. That is the path. I mean, to expect that the goal is to live a life that is free of disease or free of aging is wild, right? And yet that's sort of how we think about maximizing health. But what if that's embraced as part of the journey? But as long as it's happening in community and in solidarity, then it isn't a failure to thrive.
I'd like to even kind of bring it back and reference the second case that I talked about of the expecting woman who had all the different external factors that I mentioned, right? And I lay it on real heavy just to kind of really send home the point. But one thing that is not portrayed when I speak of a narrative like that is that in speaking to her, she seemed to come off as she was thriving, right? She was pregnant, she was glowing, she was happy to have additions to her family, and all those things were added as, what we see as care providers as barriers to care and influences to changing her outcomes. She would probably, by her definition, say she's thriving. She's expecting and glowing. And in addition, I added in that little line that she talked about her 17-year-old daughter who's trilingual, going to college. Like that was her beaming pride of that is the pathway to her family thriving. So I think that's where the solidarity comes in too, is seeing that they're, as you mentioned, taking away these like really concrete benchmarks and respecting people's own definition of what thriving is.
And I'd like to also add that I think that in addition to thinking about thriving as a social act, that perhaps building solidarity is really also about sharing stories. That so much of what we can do is how narrative not only makes us human, but narrative is also what makes us social beings. And so I think the sharing of whether the case studies that you were sharing from the clinic of the patients that you see, or also the data and also reconfiguring metrics, these are all really significant stories that can be I think really begins here at John R. Lewis College, really where students can learn how to think about narrative as very, very powerful. We see, fake data, fake stories also. And so we also know it's important to think about how to build solidarity that is, potentially facilitating thriving for all, not just for the few.
And I think we also heard today, I think through much of your work is a type of restoring of the data, an identification of those absences, and really asking us, what are these absences in these data showing us? And how is it potentially an incomplete story that people have been taking in? And how can we start to kind of complicate this and go in deeper into those complexities? And I guess I'm going to ask one last question along this line, is to continue to go into the complexities, but also as we're talking about solidarities, all of you all, I think, are showing up to your research or showing up to your practice with certain sensibilities and moving into those complexities. And I ask this question, what is the responsibility of the researcher or the practitioner in supporting kind of this type of re-envisioning or a reimagining of thriving or a reframing of health? And I think, Dr. Gamboa, you provided some really wonderful, I think, examples of ways in which you're looking through your practice, not just at the biological measures of your patients, but really looking holistically at the whole person and the whole person as a sovereign person that is able to, has their own perspectives and their own worlds. How is this also important in thinking about pathways or thinking about supporting students and thinking about ways of through your work as researchers and also as professors and also as practitioners? What are your commitments to upcoming scholars or upcoming practitioners?
I can go ahead and start with that. The work I'm able to do as a physician is it's an honor. It's an honor to do that. And I say that with a lot of pride because I did not come from generations of doctors. We did not sit at the dinner table talking about pathways to healthcare. As mentioned, I come from humble beginnings of farm workers. And so I want to really kind of send out to the students a message that your narrative, your story is just as important as the next person, and that using that is your power, right? That is your cape. You use that to then enter a field to add your background, but also add the lens that you look through. So when I see patients, I see my mom, I see my tia, which is aunt, I see my abuela, which is grandma, and I'm able to do that and treat disease and use my expertise, but also have sensitivity and when I need to pull back. Right? When my professional opinion, when all the training and 14 years of schooling, everything, when it's too much. And I think that is really the power of where students are at right now, is that you guys all have gotten here with your own story, and what the next steps you choose to do, it can come from a place of using everything you've brought along to this point and more. And that even though you don't see persons who look like you when you're desiring to enter a field, again, that is your power. That is what you carry with you, the uniqueness you have, and all of that it can be extremely scary and unnerving at times, that you have to push through that and finding mentorship. So my commitment is through mentorship. It's through being representations in my community. And then truly just having the humility that the work we do, working with patients or doing research, it's all from a place of selflessness and knowing that I'm not going to know everything, right? And that's the beauty of it all.
Well, in many similar ways, what I do as a medical anthropologist is really try to train students to first listen, and to listen not from one's ears, but from the heart. That listening is a very powerful act of being together, being present. And then from that, to be able to think about research that is not about finding answers right away, but asking good questions and helping students to learn how to become excellent researchers from the ground up. And especially for medical anthropology, it's not just gathering individual stories, but how collectively these individual stories build up to reflect on broader systems. And then to be able to understand these structures or infrastructures of medicine, such as the hospitals, such as the clinics, such as the insurance companies that withhold access, for instance, sometimes. And so to help students to think that, again, with what Dr. Gamboa is saying with regard to power, that our student researchers have amazing powers to be able to not only make a difference here, but in their own communities. And I think that's our job as faculty and also as researchers, to help students make those connections between what they're reading and studying and what they have the potential to do.
Lovely. I want to just kind of sit with what you both have shared. I think I still am figuring out this question for myself. I think that in my path, there's been a transition from idealism to disillusionment and a kind of rebuilding from there, if I'm honest, about the role of research. And what I have found works for me is to, I feel most authentic, not in the researcher role, although I do recognize the power and the authority of the researcher role. And I think that the main commitment I have is to use it to challenge other storytelling and research that is wrong and that denies people their rights and their full humanity. So that is, to be honest, what excites me, is that kind of subversive role of the researcher, that I can be in the same room with some of the voices that I think are most problematic, and I can use the same tools, like quantitative tools, to challenge some of those narratives that often get a lot of authority and respect, and I think do a lot of harm. And then on the other side, just trying to be in relationship with others and show up. And I think that being here at Santa Cruz is a real step in that direction for me, to be with other colleagues and community members that I see doing this work that makes us all feel more whole and more loved and more safe.
I'd like to add that for me, yes, it begins with the students in terms of the inequalities of vertical relationships between professors. But the students, I find, particularly around the topic of type 2 diabetes, students know a lot about it from their families. There's no shortage of people with stories about type 2 diabetes, they find. So I try to urge my students to consider writing a senior thesis. Several of them have. 2 of them have won awards. One of them did a study on healthcare in the Santa Cruz County jails. Fabulous, fabulous study. But the hardest thing is what Laura Nader would call studying up. And that is for the researcher to study and to make contact with those in institutions and positions of power, influence, people who set policy, people who get the mega bucks in terms of funding. The epidemiologists recognize that they need us, but they don't know what to do with us. It rubs them the wrong way that they even need us in the first place. But the fact is that they realize that they need to better understand the narratives behind the numbers. And to that extent, medical anthropologists, social scientists, medicine, science, continue to make these brave inroads to these areas of bioscientific research, which are still trying to understand the ways in which qualitative work can be an essential part of their toolkit moving forward, and in that process allow or make room for greater leverage between research stakeholders in these efforts.
Well, thank you all for such rich conversation. I think I'm echoing I'm going to sit with this for a while. And as we sit with it, I believe it's also time for us to move out into question and answers. So I'm going to hand it over to Chris Benner.
Thank you, Lynnea, and panelists. I'm Chris Benner. I'm the faculty director of the Institute for Social Transformation. And there are some great questions. I'm kind of going to ask them in pairs. And if there's anyone in the audience here who has a question, I'm going to start online, but please come up over here and we can have you ask the question after these online questions. So the first pair of questions has to do with federal policy. And Cindy asks, I would like to ask the panel members' thoughts about how students can get more involved with respect to positive change in national health policy as John R. Lewis leaves as a legacy. And this question is within a context wherein public service is not always considered a noble profession. Public health officials are being harassed, their lives threatened. Washington seems a distant land, although federal legislation is really important for changing access to health and changing social determinants of health, sort of structural factors. So how can students get involved in that? And then the other question is about the ways that national debates about health policy have focused on access to health insurance, which doesn't address any of the issues that you all are raising here today that are so important. And even at a state level, there's discussions about single payer health insurance. So the question is, what do you know about state or federal efforts to address the decades of underinvestment in public health, and what can we do to help expand and support those efforts?
I can jump in to start on this. I think one thing that's really interesting, I taught a class this last term called California and the Quest for Health Equity. And I think one of the things that we can learn from California as an example is that many aspects of what we're talking about, the social determinants of health, are actually increasingly legislated at the state level. And this has happened probably in the last 40 to 50 years, if you think about what's going on in the US, but we really haven't had national policy. There are few examples that didn't start at the states that are shaping the things that we're talking about around everything from immigration, well, not immigration policy, but criminal justice policy, education policy, housing policy. A lot of these things are increasingly legislated at the state level, and also because of different things around devolution and states' rights, that the state is kind of where it starts, but it stops, but it's also where it starts for students. And that's an interesting place to start in terms of local involvement and local advocacy around state policy. I mean, we have things happening in California right now that are super exciting around reparations, around housing justice, around immigration policy. And often those things start in California at the state level and then go on to shape national policy. The inclusion of undocumented immigrants in Medi-Cal, and the ways that we can show that we can do this in California and make it more possible to do it at a national level.
Mm-hmm. And I'd like to add to that looking at, this carpeted box of health policy, if students have opportunities to enter by talking about food justice or housing security, that's linked to health. So we all talked about today. And so even though, it may not be as appearing that it's specifically targeted at health policy, it's all interlinked. And I think that getting your foot in the door with whatever kind of speaks to you is important. And again, all roads kind of tie back to things being intertwined. So I think really trying to release yourself from, it needs to be labeled this health policy activity or this lobbying activity. If it's something about that is not seemingly health related, it often is. So just starting there.
And just a really brief information, there's amazing things happening at the local level. And I want to encourage our students, especially UCSC students, to know that in addition to Salud para la Gente, there are all these other nonprofit, non-governmental organizations, as well as the county public health, which is constantly seeking new employees. And so it's not just about jobs, but actually about research, where finding a research topic can eventually, as Dr. Alicia Riley is pointing out, can turn into policy later on. So things, for instance, with regard to mental health, psychoactive drugs are now becoming considered as another alternative or as a documented way to treat mental health concerns. That's amazing, right? This is just over the past before the pandemic, but even more so during the pandemic. So just incredible things that are happening at the local level, including the fact that I believe Santa Cruz County has set up a new health district, which is a new formation and just an amazing thing that can be researched as well.
So Nancy, you have totally anticipated the next pair of questions, which is awesome. But I'll just rephrase them because I think it'll help spark more of what you're sharing, which I think is really valuable and people are interested in. So Joel asked, the panelists didn't say much about the role of local government till now. How do you see the county role in addressing health disparities, and how is our local entity, the Santa Cruz Public Health Division, doing in collaborating with the community in these larger strategic issues and approaches approaches. But that's linked with another question about community health workers. James and Christina both mentioned the importance of community health workers. And it's a question of, can you talk, they're kind of invisible in our health system. And so can you say more about how widespread they are, more examples of what they do and can do, and how do we increase public investments in community health work?
Yeah, I can start addressing that question. And it's a great question. I think I forget now who's mentioned it, but the community health worker component is such an important piece because it's the stories closest to the cause, right? Closest to the issues. In certain communities, we call them promotoras. And when speaking to one of my colleagues recently about kind of what we've collectively been done to partner with the county and create partnerships throughout the county, she reminded me that where we're at and the work that's been able to be done in this massive way started with work groups from promotoras, from community workers. And so I think that is unfortunately one aspect of, when we sit up here as representatives, we always, at least for myself, and I'm sure for our panelists, I'm always carrying on my shoulder all those who I know who've done the work that I am here to talk about it. And, I think that having that awareness is important, but also finding ways to give recognition to the workers is important, but they do exist. They do exist, and the collaborations that I mentioned with this collective impact model that the county has really made more robust in the past couple of years started with work groups, or at least has created work groups that are based in the community, based with the model of you tell us the stories and we'll do the work.
If I may add, what I found in my work is that community health workers are a part and parcel of the community. But in speaking with people in the federal government, the question for them is, do we have to pay these people? Where is the money coming from? We don't have it. And not only that, there's this issue, once again, of professional gatekeeping. So the community health workers who I interviewed were basically conducting and holding classes in places in which the public health people or the hospital diabetes programs did not reach out to, because there are actually health centers here in California, in the Bay Area where I did most of my research, that actually charge a fee for diabetes patients to attend their diabetes classes. They're not free at all, and they have to pay for them quite often through their insurance, if their insurance covers it. So there are these stratified layers of inequality in terms of the message and the messenger that still exist around health and health education.
I just wanted to jump in and answer the other part of that question, which was about county public health departments. And I think I would say the answer is that it's up to us. We have seen that we have failed our county health departments during this pandemic. And it starts in Santa Cruz. There's an amazing This American Life episode about the actual violence that was threatened against our county health department leaders during the pandemic. And this is not unique to Santa Cruz. We see it across the country, but I think that if we want more local representation and an expansive view of health and thriving, I think that we need to invest in our county health departments.
Are there any questions here in the audience in person before I jump to the last ones online? Yeah, please come on.
So hello, my name is Ariel Silva. I'm a John R. Lewis here affiliate here. And I'm also one of our college's leaders in the Black Student Union, and I'm Black and Latina. So speaking to many of the lived experiences of the panel today. And I can't help but question, if we're bringing up wellness and livelihood and like the imagining of something that is better. And like this whole process of the renaming has been really ironic in some ways for our own student experiences, because a lot of the BIPOC students here are still feeling the effects of COVID, of still having to pay the proper tuitions, in quotes proper, because why are we paying as much as we are paying for something that could possibly be remote, or feeling the effects of what it means to be a BIPOC student dealing with health concerns in a predominantly white institution. And so I want to ask, with the most recent, the masks are coming off in like T-minus 4 days. And I say that as my mask is falling off myself. The K95s are pretty tricky, but they're saving lives. So this is what we have to do in order to adapt. So I want your opinion on the university's decision to remove the mask mandate on our campus. And how do you foresee that? How is that going to change your relationships, not only as educators on campus, but also with your students? Like, how do you see that impacting what is happening on our campus? Because if that's changing our relationships with the Santa Cruz County Health Department, or how we're dealing with that, because you can't help but feel the effects of, we're literally hearing stories of people that are dying left and right. And then, we're going through this renaming process, but we're lifting mask mandates. How is that going to honor John R. Lewis's legacy? Because that to me is taking a step backward when we're supposed to be taking a step forward while also honoring him and the BIPOC students that are here. So thank you.
I can say something you can first.
Yep.
I want to thank you. That was a brave question.
Yes.
And I appreciate the way that you grounded it. And I think it's a really important one. And I think that I've said this before, but I think that the loudest voices in the room are not those who have paid the biggest toll during this pandemic. And I think that a lot of policy is based on an incomplete story of what's going on. And even right now, I would point out that, we don't have a university policy that allows for symptomatic COVID testing on campus. And so what that means is that our testing numbers are inherently biased, because if you are sick with COVID, you have to test off campus or outside. And so there's a lot of issues that are important to be in conversation about. And I think that one of the things that we learn about this whole process of the pandemic is that in order to guarantee health or thriving and to recognize the right to health, there has to be a process that people feel is authentic and that they feel a part of, and there has to be transparency, and it has to be a dialogue. And it's hard to do that when there's a power imbalance. I feel concern, and I share the concern that you have. I mean, I'm wearing a mask up here, and I think that my own research speaks to the power of masks. I mean, we know that when we look at working age people in California who died of COVID during the pandemic, doctors and nurses are not the highest people on that list. It's groups of occupations that didn't receive the same attention and protections. And so I think there's a lot that we haven't talked about and haven't learned yet. And so that's all I'll say, but to thank you for your important question.
And I also want to join in thank you for asking this question, because the mask mandate is really just the tip of the iceberg. And as Dr. Alicia Riley has pointed out, it's that there's so many other issues related to power. A lot of historians of medicine have talked about, I've always attributed it to Galen, but it's the wrong, different figure. It's all medicine is politics, right? And so we have to understand that, in health as well, or access to health, there is this issue of power. But as Dr. Gamboa pointed out in one of the remarks, well-being is part of a whole broader context. It's not just simply, one's blood pressure or one's, weight or other things. It's really about access to housing, access to food, access to education, access to generational well-being, right? So not just thinking about the individual, but the whole community, the whole family and the whole community. So for me, I think of, as the policies for mask mandates are, literally changing. At the same time, there's still communities that are heavily impacted, and we have to pay attention, right? That it's not something that we can just simply say, oh, it's because we don't see it, it doesn't exist. I mean, the whole lesson of this pandemic has been about what we don't see, what we don't hear is actually where we have to pay all the more attention to. So I thank you for raising that question, because it's not, there are no easy answers, right? And even here, being up here, we were told we had to test, and also it was a big decision whether to still wear the mask or not. So I thank you for all of you here for wearing the mask today in person.
Yeah, I'd just like to add that, there really is not a clear answer. And I think that we will continue to have these questions posed to us in the future of how to shift things, how to mandate things, how to release mandates. And I think the most important lesson to come from it is really, as my colleagues here have mentioned, is really trying to make inclusive decisions, or decisions that are engage inclusiveness for different populations, and not have this blindsided approach of like, oh, well, everyone's doing great and we're all traveling again, so therefore we live in a healthy world. I mean, this is just an example that of what will probably happen again in subsequent years, so I do think your question as well. And I don't know the answer, to be honest. Like it's really hard to get to a place where we have so much trauma in the last couple of years to move past that, but we do have to move past it. We do have to move past it. And I think the most important way to do it is with inclusive dialogues of what that looks like and what feels good to people, what feels good in your space. And that might change if you're on this college or another college. But I think just having honest conversations and having representation of what we are seeing and what we know is impacting our communities and our families is the most important way to move forward.
I also just want to add one thing, and I'm not a scholar that situates myself predominantly within health, but I do know that when this pandemic started, there was a transition to really thinking about consent as something that's shared, right? And the mask really was about not only you, but your communities and the people that you're with. So it really calls into question, how are we, what does that consent really look like? And if there are clearly unconsenting people in the room, what are the types of conversations that need to happen in order for us to redress what harms that might been done, or to come to spaces in which people do feel relative levels of safety. And I think that in that sense, the pandemic has really called us to even question these really individuated notions of health and taking care of and taking care of yourself, and what does that look like? I also just was told that would be our last question. I just want to take a moment and thank all of our panelists today. Thank all the people who asked questions, and let's give a big round of applause for everyone.
Please join us in actually another round of applause that includes our wonderful moderator and these incredible presenters, and for all of you in this room, online, for being part of a really powerful conversation this evening. Thank you. In the digital handout, we acknowledge that many people made this evening possible, and we share our deepest gratitude to all of them.
And in that same digital handout, you will note that the final Necessary Trouble event, which is next Wednesday, April 13th, again at 4 p.m. in this same place or on Zoom. Our series wraps up with an event led by our organizational partner, the Center for Racial Justice, that focuses on students as agents of transformative change. So we encourage everyone, especially our students, to attend in person, to enjoy the panel as well as tabling efforts before and after. And please mark your calendars again and join us 1 week from today. And as has been announced and was mentioned earlier today, we have our dedication celebration for College 10, soon to be John R. Lewis College, on Friday, May 6th. It again will, doors will open at 3 p.m. It starts at 4 p.m. It's in our Quarry Amphitheater, in person only. So sorry, Zoom guests, you'll need to join us in person. Check out our website for more information. It's also in the digital handout. We look forward to officially becoming John R. Lewis College in just a few weeks on Friday, May 6th. For those of you in person, we invite you to grab a to-go box of food on your way out due to COVID protocol. We're not going to be eating all together today, but please pick it up on your way out. And thank you again, everyone who joined us both in person and online in this event series commemorating the naming of John R. Lewis College. Thank you.